Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is the audio version of the past week's summaries, which this week were brought to you by our authors, Joshua Belfer, Shannon Marcus, Josh Dodge, Ketan Patel, Vivian Lay, and Clay Smith. Okay, then let's skip to the second article, titled Successes and Failures of Emergency Department Trauma Intubations, out of the Canadian Journal of Emergency Medicine. Now, I didn't really realize that trauma intubations had a lower first-pass success rate than usual intubations. But I guess that's fair because you take the normal person, and while you're complicating them physiologically, you're also complicating them anatomically, perhaps, or at least there's the potential for that depending on where your trauma is. I imagine that, outside of having some trauma to your face, that most of these cases are because we're worried about their necks, and thus we're making the intubation harder on ourselves in order to not move that patient's neck. So this was a retrospective cohort study of 440 trauma intubations from 2 Canadian level 1 trauma centers, and they wanted to see what are really the outcomes that are happening, what's happening with these patients in terms of airways and trauma. They've had an 85% first-pass success rate and a 22% adverse events rate. Now, if you want things to go better, video laryngoscopy was associated with improved first-pass success odds ratio of 2.4, which is good. We know that already. We know that video laryngoscopy is the way to go. However, if you're worried about things getting a little bit worse, getting a little bit dicey, then having head, face, or neck trauma decreased your odds of success. So an odds ratio of 0.09, which is quite significant, and was an 11% decrease in the overall first-pass success rate, with 6% increase in adverse events, which is pretty significant. And overall, a lot of these patients were fairly sick. From a sample of just 440, one of them got a crike off the bat, and 2 got crikes after attempting intubations. Other things that you can typically figure are not going to be good predictors of success are increasing attempts, of course, then it's hard, and having a junior operator. So having a resident in their first or second year had a decreased odds of first-pass success, unfortunately. So you had more adverse events in that group, but we know that less experienced people have less experience and, they still have to try. Sometimes just be careful with it. Because having a junior resident intubate had an associated rate of adverse events of an odd ratio of 2.12. And so you had significantly more adverse events. Always, have a backup plan, have a time when you want to take over from a junior learner, but all the same, sometimes they're going to be the ones taking the intubation. That's very important for them to do. All the same, you have to practice to become, a senior resident who's good at these things. In a spoonful, in trauma, first-pass success is a bit lower than in, regular patients. It's worse if you've got some kind of head, face, or neck trauma, and things go best if you use video laryngoscopy. Okay, then we'll skip to the fourth article, titled, Does This Child Have a Concussion? The Rational Clinical Examination Systematic Review out of the JAMA. I love these articles. I love the rational clinical examination. This is something that's really important, and I try to incorporate these articles into my everyday practice. This is a pretty important one as well. This is pediatric concussions, which is something that is not seen infrequently at all. Kids tend to run into each other and run into things, and a lot of kids, more than adults probably, do a lot of sports, and as a result get a lot of concussions. So how do you evaluate these children? What is the best way to evaluate these children? What is the usefulness of the exam maneuvers that you can do? Let's answer that question. First, let's talk a little bit about concussions. So concussions are, of course, due to trauma. And this trauma causes the injury of cells, which triggers, sort of mass sodium and potassium fluxes, which causes widespread depolarization. This, combined with an alteration in the cerebral blood flow as a result of the trauma as well, causes energy demand mismatches leading to inflammation and damage. And this results in symptoms and what we call a concussion, with a disruption of networks involved in balance, vision, cognition, and mood. And then the symptoms that we see in our patients, which are headaches, dizziness, visual disturbances, slowed cognition, and emotional lability. Symptoms typically develop over the first few days, but they do start immediately. The damage is there immediately. Now, there are many parts of the exam, and it really depends on how accurate they are as to when you do them. And so there's a lot of nuance to a lot of this. Let's try to keep things focused for what's really relevant to the emergency department. Now, I'm going to tell you that it's very hard to rule out a concussion because the sensitivity of most of the tests that you can do is frankly terrible. However, the specificity of several of the examination maneuvers that you can do are actually quite good, as are some of the symptoms that you can ask your patient about. As a result, I'm going to tell you about the highest yield tests, and those are really the ones that have a positive likelihood ratio above or around 6. Though, again, keep in mind that ruling out a concussion is very difficult. Now, by way of symptoms, having mental fog, noise sensitivity, nausea, and light sensitivity are going to be the features that really clue you into, hey, this person probably has a concussion. These are symptoms with high positive likelihood ratios. As for signs, near point convergence, which is farther than 5 or 6 centimeters from the person, is also going to be a very specific sign that this patient has a concussion. Otherwise, you should also look at smooth pursuits and look for abnormal saccadic eye movements. These are really good tests to incorporate. Now, the only thing that you can really do that has a decent negative likelihood ratio and also has a very good positive likelihood ratio is the presence or absence of a headache immediately after the injury. A positive likelihood ratio of 8.7 and a negative likelihood ratio of 0.06. In terms of sort of getting something like a baseline and following these patients to see how their symptoms progress, these authors recommend the SCAT6 and Child SCAT6 tools. These take some time to do, and I do not think that you should be performing them in the emergency department. However, just know that people might be doing this in the follow-up that you give patients. That is really going to be my major takeaways from this article, and I'm going to incorporate these in all of my examinations for concussion. So we have things that are going to make me much more certain that the patient has a concussion, and we have one thing that's going to help me kind of rule it out. For the most part, though, it's very hard to rule out a concussion, especially in the emergency department, as you expect symptoms to sort of evolve over the next couple of days. That's why it's really nice to get these patients follow-up. In a spoonful, there you go. Now you have some help with concussion evaluation and diagnosis in children. Okay, that's all the 5 articles from this week. Let's do a quick wrap-up of everything we talked about. Then from the second article, if you want demographic data on trauma intubations in Canada, this is a pretty good paper for it. It showed a quite good first-pass success rate of 85%, with head, face, and neck trauma decreasing the odds that you have first-pass success and increasing your adverse events rates. Also, having a junior resident intubate was also not great, and video laryngoscopy, it still saves the day. From the fourth article, we went over the rational clinical exam for concussion in children, and we learned some things. Now, if you were hearing this right now, then you were not a part of the members feed, and so you missed 3 articles from this past week. What were those articles about? Well, we covered a huge trial comparing NS to LR in children. Then we looked at the long-term outcomes of the IVIO trial. And then finally, our fast MRIs as good as CT scans for general neurological complaints in the emergency department. Links to all the original articles can be found at journalv.org, or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.